Welcome back to Clinicians Brief, the podcast, where we unveil the conversations behind the content. I'm the host of this show, Dr. Alyssa Watson, and today I'm honored to welcome a new distinguished guest, Dr. Sam Babbitt. Dr. Babbitt is a veterinary dentist and oral surgeon at the Virginia Veterinary Center in Richmond, Virginia. He's here today to guide us through recognizing, managing, and hopefully even preventing some common complications that you could see during dental procedures. Being a skilled surgeon, it really is not only mastering all of the correct techniques, but knowing what to do if and when something unexpected occurs. And that's what we're going to be talking about a lot today. So we're going to be taking a deep dive into Dr. Babbitt's experiences and insights, and hopefully equipping you at home to respond effectively the next time you encounter an unforeseen challenge during one of your dental procedures. Good morning or afternoon where you are, Dr. Babbitt. Thank you for joining us on the show.
Good morning. Thanks for having me.
Before we jump into some of these complications, I was hoping that you could take a minute to introduce yourself to the audience, give us a little background, a little bio.
I graduated from Virginia Tech in 1990, so a long time ago. I was in general practice for 24 years before I caught the dental bug, if you will, and sold the practice and the house and farm and undertook a residency to become a dentist. And I've been boarded since 2017, I think, and currently working in Richmond doing dentistry and oral surgery, and I love it.
That's wonderful. That is just, it's a great, not something I hear a lot, where somebody, like you said, gets the bug 24, 25 years into practice, and they're going to go back and specialize. And I think that's awesome. So
some folks would say I was crazy.
No, it's great. I told you, before we even started the podcast, dentistry is not my cup of tea. And I think that's because I've been in practice 20 years, and I really didn't get a lot of training in school. And then I ended up working at a practice that had 6 or 7 veterinarians, and one of them was a fellow of dentistry. And because he kind of took all those cases, I didn't get a lot of training after school either. And so I felt really behind the 8 ball, when it comes to that. So reading some of these complications and thinking about some of these complications actually gave me a little anxiety, but we're going to work through it. I'm here. So the first complication that we're going to talk about is gingival flap healing, poor gingival flap healing. And so I was hoping that you could walk us through the key goals and considerations. What should I be looking at when I'm designing, before I've even made the first cut, when I'm designing that gingival flap?
Well, sure. In my experience, the most important thing is to maintain a good blood flow to the flap. So that means a nice wide flap, hopefully not created very traumatically. And so nice wide face, or maybe an envelope flap. And that way you've got good blood supply to it. And trimming away any bad tissue, diseased tissue, raggedy tissue that might be there, so you can suture healthy stuff together. And most importantly, no tension on the flap whatsoever. I think that's probably the biggest flaw that I see where flaps are sutured, because the surgeon maybe doesn't quite have the ability to get that tension released, and they decide to suture it anyway, and those invariably will be the ones that are most likely to fail.
That leads pretty nicely into my next question, which is kind of the difference between a pedicle flap and an envelope flap that you mentioned. Could you just explain, kind of the differences between those, and maybe provide some examples of when you would use the pedicle flap versus when you would use the envelope flap?
Yeah, sure. The envelope flap is just, as it sounds, it opens like an envelope. That's made by that's kind of intrasulcular incision along the teeth, right at the gingival margin, and then opening that flap up is just one, almost like a clamshell. And versus a pedicle flap where there is a release somewhere, maybe on one side or maybe on both sides, a vertical release that allows you to just lay the flap completely out of the way. In my experience, I've taught a lot of folks dentistry. Most times for folks that are beginning to learn, it's probably better to do pedicle flaps because the exposure is greater. You can see better. They take longer to suture back, but you get a better visual, and I think it's probably a better place to start as skills become a little better, perhaps moving over to envelope flaps because the exposure is not as great, but the closure is much faster and much less worry that you're going to maybe damage the flap while you're trying to lift it up. Uh, so I think I answered your question.
Yeah.
I went a long
No,
ways there.
absolutely makes a lot of sense. You kind of same thing when you're starting out, doing a spay. Your incision is a lot longer than after you've been doing it years and years, and you can make that incision a little bit smaller and feel comfortable, with a little less exposure. So that makes perfect sense. Can you discuss the techniques and considerations involved when we're doing those periosteal releasing incisions, including what instruments should I be using, and how do I not damage my flap? Because that's something that has happened to me, where I punctured through the flap and then I don't know what to do.
Yeah, awesome. Yeah, this is probably the most important part of the entire process with the flap and closure, and maybe the part that is most confusing to some of the surgeons who are starting to learn how to do dentistry. The release is basically from the back side of the flap. What I see, and I've taught I think probably hundreds of veterinarians by now how to do these flaps, and the most common description I get from them is they're because it's a periosteal flap, they're releasing off of the bone, and that's really not going to gain the release of the flap. The periosteum is actually attached to the flap, and so making a release off of the back side of the flap is how you actually have to release it and get that mobility. That can be done with scissors. I'm big with that. I was in general practice for 24 years, and soft tissue surgery was my thing, and I'm very happy to release it with scissors. A lot of people prefer to use a periosteal elevator, say a molt elevator, to make that release. You can actually use a scalpel blade just fine. What you do when you're using a scalpel blade, so you don't hopefully poke through, as you say, is sort of roll the flap over your finger a little bit
Mhm.
and use your finger as a backstop. I have found when I teach people to do it that way, they're a lot less aggressive because their fingers on the other side, and that way they use a very light touch and releasing that periosteum. You'll see the flap release immediately when you've done it the correct way.
Mhm. And then what type of suture are you using? What pattern? Do you close these with a continuous pattern? Are you doing simple interrupteds in order to get these flaps closed?
Awesome. Yeah, I tend to use monocryl. I like monocryl because it's monofilament. It hangs around for 3 or 4 weeks. I like the handling of it, and I like that it stays a little longer maybe than I really need it to be there. But some folks will use chromic cut, and they have very good results with that. I'm not a big fan of braided sutures. I have used them in the past. Your Vicryls, I think they tend to be more reaction to those sutures and more problems for me dragging them through the tissue. So I tend to stick with monocryl, and that's what I've used for probably 6, 7 years now.
And you said that monocryl might last a little longer than you need. So, what is the general timeline of healing when we're talking about, these surgical wounds that we've created in the mouth?
Yeah, I think it's a week or two, and I always restrict my patients' diets for 2 weeks when they go home if I've done some sort of invasive surgery. I think it takes that long. I used to do say a week, but I had some cases over the years that dehisced after a week, so now I say two. And I just simply don't have problems with that. And some of our owners are a little unhappy that they have to restrict everything for 2 weeks, but that really is I think, the minimum to make sure you get good healing. And I'll still tell them even after that, don't chew on anything hard for another week.
Yeah.
No bones, no rawhides. Shouldn't be chewing those anyway. But if you're going to do it, don't do it for another week because we don't want to put any pressure on those wounds.
Yeah, that was actually going to be my next question is when we do see dehiscence, when is that? Is it right away, or obviously it can be delayed a little while?
It can. It's usually pretty soon after the surgery was done. In my experience, I'll preface that to say that I generally don't have dehiscence from my own patients. They're patients that have come into me. Uh, I think probably once every 2 or 3 years, I'll have a case that has a dehiscence. And it's mostly because of the good flap design and suturing. I think you asked earlier about the suturing patterns, and we didn't
Hmm.
get back to it.
Yeah.
I think I skipped over it by accident, but generally, I'm using simple interrupted. You can use a continuous suture. When I do, I'll use a forward interlocking. I tend to do that with some of our total mouth extractions where I've got a big
Hmm.
wide envelope flap. And so I'll use a forward interlocking suture. Occasionally, some horizontal mattress sutures, depending on the situation. Very occasionally, a cruciate suture, but usually it's either going to be a continuous forward interlocking or simple interrupted.
And then one consequence of poor flap healing, especially when we're dealing with certain teeth, is the development of an oral nasal fistula. And so that's going to be, an abnormal opening between the nasal and the oral cavities. And so what are some common causes? What teeth are usually involved when we're talking about these acquired oral nasal fistulas in dogs and cats?
Yeah, the canine tooth is the most common by a long shot, but oronasal fistulas definitely occur behind the canine tooth. I see them commonly with the third and fourth premolars, particularly in brachycephalic breeds, where that third or maybe even the second premolar is sort of rotated 90 degrees, and that palatal root is out there, very thin bone, takes very little periodontal disease to open up oronasal fistula in that area. But definitely the canine tooth and the premolars are where you see it the most commonly. Uh, Mostly it's going to be due to periodontal disease, but you will definitely see them from trauma. We'll see them sometimes congenitally as well. Electrical burns. You'll see it. Radiation treatments
Mm.
for dogs will sometimes create them, but mostly it's going to be periodontal disease that's going to lead to it.
And what is the clinical presentation of those animals, that have an oronasal fistula from chronic periodontal disease or maybe even trauma, like you said?
Yeah. Sometimes nothing. And honestly, I've seen plenty of them that the owners don't understand why they're there. The veterinarian sent them in because he has a hole in the mouth, and they say the patient's just fine. So sometimes no symptoms at all, and probably more commonly it's sort of a chronic rhinitis symptom. So maybe a chronic nasal discharge, some sneezing. The dogs will sometimes be pawing at their face on that side, but mostly it's going to be a rhinitis sort of situation.
Okay. And then are they typically diagnosed just with physical exam? When might you need something more advanced like radiography?
I think most are diagnosed on physical exam when they lift the lip and they can see it. Certainly, radiographs can help. CT scans also can sometimes find these, particularly the ones that are more caudal. Those are the ones that tend to trick people more when they look in the mouth and they don't see that the canine tooth is abnormal, but they see periodontal disease more caudally and don't really think necessarily of an oronasal fistula. But radiography, I think, is less valuable, to be honest, than clinical evaluation. And once they're under anesthesia, placing a probe into that area and it just drops into the nose, then you've got your diagnosis.
Okay. And then what are the key factors when we need to repair these?
Gets back to our flap design. I mean, it's all about the flap in my mind. You need to have a good flap with a big wide base, good
I'm
blood
gonna make
supply.
make
Get
t-shirts. It's all about the flap.
all about the flap. Get that nasty raggedy tissue off the end. One thing that I do that really improves healing and improves my success rate. And again, I very rarely have these open back up again. And that is going to be to what I call scarify the base of the flap. So when you raised up the flap and you're going to attach it to the palatal side, on that palatal side is going to be granulation tissue, epithelium that's really thickened and sometimes rolled over. And I take a diamond burr, usually a cylindrical diamond burr, and I just take all that epithelium and granulation tissue off at about a 45-degree angle, as wide as I can make it, and then I attach my flap to that. And I use mattress sutures, horizontal mattress sutures, to disperse a little bit of the pressure on the flap. And then in between, use simple interrupted sutures. And when we get done, it's super tight and it heals almost every time.
What is the prognosis for these patients, like if that correction is not possible, or is there, are there other techniques, mesh or something to put in there, when you can't get it closed, when you just don't have the tissue?
Yeah, well, I think that the short answer is I always have the tissue, and the tissue's always there. It's a matter of where you're going to get it from, and that's the challenge. That's why they send them to me, because it can be a challenge to find tissue. But once I find tissue and bring it in without any tension, I'm good. Occasionally it will be an issue where the tissue just not there, or we do have a case where maybe it's been operated 3, 4, or 5 times previously, and there's not a whole lot left. And I don't use a lot of uh, meshes or grafts or anything of that sort. I just use surgical technique. And in some cases, I have to do a little fancy footwork and maybe make a 2-layer closure where I might flip part of the palate over and then cover that with a mucogingival flap to give me a little better healing. But that's pretty rare, to be honest. And I can't think of a single case where I've ever had to put a graft in there. Although I do know some people do that. They'll use tissue grafts or bone grafts, little sheets of bone graft. I just don't find that necessary in my hands.
Are there any red flags that me as a general practitioner either breed or a specific tooth, so that we're not trying to repair this 3 or 4 times before it comes to you? Like what should I say? Okay, this is really beyond the scope of what we should be doing and I need to refer it.
Yeah, I think that boils down in my mind to the experience of the veterinarian, of the surgeon that's doing it. If it's something they've never done before and it's a small hole, I think go for it. Use the good technique. If it's a giant hole and there's not a lot to work with, probably better off not to try. And quite frankly, some of these have come from boarded surgeons that have tried 4 or 5 times to close some of these. And so it's not just inexperience. Sometimes it's just you need me, to come in because I do so many of them. But I think certain breeds are very predisposed to developing oronasal fistulas, and it warrants mentioning here. Dachshunds for sure. They in my mind have an oronasal fistula or a problem on the back palatal side of the canine tooth until proven otherwise. No matter what it looks like when you lift up the lip, it's so common that on the palatal side of that maxillary canine that there's a deep pocket there, and oftentimes it's an oronasal fistula. So if they're symptomatic and it's a dachshund, when you might also include Yorkies in that list as well, super common with them. And any of the brachycephalic breeds, you'll see it more commonly, but dachshunds are definitely the poster child.
That's very helpful. Thank you. Great veterinarians want to work in great clinics. Put your clinic's best foot forward on the Clinician's Brief Career Center. It's where you can easily share what makes your clinic special and get your job openings in front of veterinary professionals with the right skills. Get started on your next amazing hire at cliniciansbrief.com/career-center. Okay, so we're going to move on to my absolute most feared complication, and that is iatrogenic jaw fracture. This is something that I've seen other clinicians in my practice do. I have not had it happen to me, thankfully, but probably because I'm very chicken. And so I'm not attempting some of these more difficult extractions, especially like in the mandibular teeth. What is the most common location for these iatrogenic fractures?
Well, you're smart. Like Clint Eastwood said, a man's got to know his limitations. And I think that's the key to not having these fractures happen when you see them. Very common reason to be referred in for me when veterinarians get their patients under. Maybe they take X-rays and say, "Whoa, three steps back. Let's punt this one because it looks like there's hardly any bone. But the most common spot that I tend to see those fractures happen is going to be at the apex of the canine tooth. That's usually operator putting a little too much force on that canine tooth. The other side is the first molar, particularly in small dogs, little toy breeds, Yorkies and the like. That first molar tooth, the root of the first molar tooth typically goes right to the bottom of the mandible. And if you have periodontal disease there, you may have very, very little mandible left. And I think a lot of those fractures are created at practices that aren't doing dental x-rays to see what they've got there, and they just start extracting that tooth, and then they have a mishap. But those are the two most common locations I see for sure.
Yeah, absolutely. That's when I have seen it. Those are the two locations that I have seen it happen as well. And yeah, I've taken that x-ray and there's just a sliver of bone, at the bottom of that first molar. And those are the ones where I usually stop. So you think you talked about pre-extraction dental radiography and why that is so important, because we really can't see this, right, without taking an x-ray first.
Absolutely. The radiographs are critical to being able to extract these teeth, because particularly in the little guys that I mentioned, where the roots may go completely through the mandible, or at least to the bottom of the mandible, oftentimes as well, the roots are turning when they hit the bottom of the mandible, and they have a curve almost like a little elf slipper. And if you don't know that going in and try to extract that tooth with that curve in it, you're very likely going to break that tooth off, and you're going to put a lot of force on the jaw as well. So they're important for that. Oftentimes, too, the periodontal disease may only be on one side of the tooth. So the mesial root or the front root may have no bone support, but the back root may have 100% bone support. And knowing that information can tell you where you need to put your elevators to try and not put force on that thin area up front. So it's really critical that you know what the anatomy is and what the situation of that pet is.
Sure. Is it ever advisable or give you more information to take some radiographs at different angles, when you're looking at that? Or did you just do kind of that standard bisecting angle?
Yeah, I think sometimes that's beneficial to take different angles. It's more so when I'm trying to decide where a tooth root is going, particularly is it going, sort of straight up and down, or is it curving? And if you're coming at it from one angle, or from like a hard to describe as sort of a rostral to caudal angle, sometimes people take you can obscure that, and so switching around and taking a straight lateral or even a caudal to rostral oblique sometimes will give you a little different picture. But most time I'm using my standard approaches. I can kind of tell what's going on.
And then when this happens, if it happens, when it happens, how does that periodontal disease complicate trying to fix it?
Awesome question. I get this a lot. So you've got a huge defect in the bone. Sometimes the tooth is just floating in that defect, but that defect is not a total void. What is in there is usually a mass of granulation tissue. Sometimes if you're talking about the mandible, the mandibular artery and vein and the nerve is in there as well. And so you have to be careful to sort of safeguard those structures. But once you remove the tooth, you shouldn't leave that granulation tissue in the hole. So you've got periodontal disease, you've got infection there. That granulation tissue needs to leave, but you have to be very careful again, because the vessels may be sort of part of that. So just carefully removing that. A lot of folks will ask me whether they should put bone graft material in that defect, and I think the answer is maybe. The way I look at it is, how likely is this bone going to fracture when I get done? If I've got a very thin little shell of a bone, I'm a little quicker to put bone graft in there. In my mind, is because I think it just heals faster. And so I don't want them to jump off the sofa and break their jaw in a week. So I want to try and encourage bone growth as quickly as I can. But truthfully, I rarely put bone graft in these sites, but I will sometimes. And that's the only reason I will do it, is if I think, oh goodness, a feather may touch this and it'll break. I want it to heal as fast as possible. But other than that, I let the blood clot heal it, and they do great usually.
Good. Let's move on and talk about fractured root tips, not fractured jaw.
No.
So, what disease processes make tooth roots more likely to fracture when we're doing extractions?
Yeah, it's much more common in my experience with your old dogs and old cats that have their poor little teeth are just fused to the bone, and you're having to extract them, and so it's very difficult to extract, especially in old cats. I find that a lot of times those teeth also have sort of a bulb at the end of the tooth root that will help kind of lock it in place, and you think
Mm-hmm.
you're getting it out, but it's actually not moving because that tooth apex is actually wider than the rest of the root. And so those ankylosed teeth, resorbing teeth are really difficult to get out. Those teeth with the sort of proliferative root tip are difficult to get out, and they're the ones that oftentimes are broken and unfortunately sometimes moved into areas where they shouldn't be left. But it's usually because of the anatomy of the tooth that really complicates things for you.
And then could you just walk us through kind of the order of steps with the when you're doing an extraction, when are you removing like the alveolar bone, all of that?
Yeah, yeah. So I tend to remove the sort of the buccal alveolar bone about maybe 50 to 75% of the root. I'll remove from that buccal side so I have good exposure of the root. There is nothing wrong with taking 100% of the bone if you need that. And I will do that when I see, for instance, some of our old dogs with resorbing teeth and they're fused into the bone. I know it's going to break. And so I just go right down to the apex of the root, take all the bone off of the buccal side so that I can get that root out. I'm going to have to do it anyway. I'll just have to do it in pieces if I don't do it all at once. And so it's fine to do 100%, but typically 50 to 75% of that bone is removed. And then if you do break a root off in there, the thing that I typically recommend folks do is first sort of flatten off the root so you can see where it is. Oftentimes they'll have sort of a jagged break, and you can't really tell where root starts and where bone starts. So I like to just flatten it off. Then you can see around it, and then I'll take a very small uh, round burr, like a quarter round burr, and go right down in the periodontal space and make like a little moat around that root so that I can introduce some kind of instrument in there. And the key to not having it go anywhere bad is to only lift on the root. A lot of folks are taught, and I was taught in 1990, what they call the rock and roll technique, where you put your elevator in and you're just sort of rocking it back and forth and you're twisting it and trying to go down deeper. And that's a recipe for pushing that root into the mandibular canal or into the nose. And so I tend to only use elevators that will lift either a root tip pick or a very tiny little elevator to get it out of there and hopefully not lose it anywhere.
Yeah. And if that happens, because we know it does, what steps should I take immediately if I lose a root tip either into the nasal cavity or into that mandibular canal?
Yeah. Yeah, this is a I guess a pearl tip for you for everybody listening. The It's very rare for a root tip, in my experience, to just disappear into the nose or into the mandibular canal. Usually, what happens is as you're working on it, it starts to go, and you can see it kind of moving off to the side or trying dropping in a little bit. And then what most people do is they keep working harder to grab it and pull it back out and end up pushing it farther and farther and farther in. That's sort of the typical. Now, your hand can slip and push it in suddenly, but that's pretty rare. Mostly it's a kind of a gradual loss and you're chasing it in there. And so what happens, and I sometimes have this happen where the whole bottom of the alveolus is not even there. And the root tip is floating maybe partially into the nose when I first see it. The key is to widen the hole, whichever direction it's going. If it's going straight in, you widen the entire hole. If it's going off in a direction, you widen it on that side, so that you don't keep pushing an instrument in. You just make the hole bigger, so that you can then grab it with something, because it's not going to be attached hard to anything. It's just floating there usually, and so you can grab it with a forceps or a small root tip pick, and just kind of pluck it out of that area. But the key is not to keep pushing it in farther. So the first thing you do when you see it going is like take a step back. All right, this thing is starting to go into the nose or into the mandibular canal. Let's change plans here. Where is it going? Let's go ahead and take some bone off. Take another radiograph if you need to figure out which direction that it's going, so that you can remove bone over that and retrieve it quickly. It's much easier if you retrieve it during your procedure than send them to me and have to track it down. But that's the key. Just don't keep working at it. That's what most people do wrong.
Okay. And then what about if you have, you take that radiograph and you see a fractured root tip, but the gingiva has healed over, everything looks good. Do you still recommend going in and trying to dig those out?
No, not necessarily. I call them sort of quiescent root tips. The key is that I don't see anything with the bone around that root tip. There's no lucency of bone. There's no draining tract that leads out to the gingiva. The gingiva is perfectly healthy. And if that's the case, I'm very likely just to leave it alone. I don't think that really is necessary to remove it. I will remove them sometimes if I'm in the area anyway. I've taken out the tooth next to it, and I'll just go ahead and remove it because I'm already there. But making a new surgical approach to that area, if it's just sitting there, I don't think you have to do that.
And then obviously you would document that in your record and everything. So
yeah, and you just follow it. That's what I always tell the owners, that we're going to just monitor this next time you come in. We'll look at it again, make sure we still are happy with it being there.
So that brings us to our last complication, which is bleeding. You had talked about that big artery. So what are the potential sources of hemorrhage when we're working in the oral cavity?
Yeah, the infraorbital is the big one that I get the most common calls about, where, as it turns out, and particularly in brachycephalic dogs, the infraorbital artery goes right between the roots of the third premolar. Most commonly in those brachycephalics, and oftentimes it is right through the furcation of the tooth. And then it goes through the furcation of the fourth premolar as well. And so if you don't recognize that and start extracting those teeth, it's very easy to hit that infraorbital artery, and next thing you know, you've got Mount Vesuvius shooting blood in your eye. And it stresses out our poor doctors quite a bit, and they'll call me right in the middle of the procedure and wonder what the heck to do. But that's probably the most common call. The mandibular artery would be number two, and it's usually going to be those periodontal cases where the bone has receded, and now you don't have bone protecting the artery in the vein and the nerve anymore. It's right there, and so when you start splitting the tooth, you don't recognize that right underneath that area is the artery. And some of our burrs create quite a bit of suction, particularly some of our number two and larger burrs. So I, always caution, if recognize where the artery is in that mandible. If you're close, don't use a big burr. Use a little teeny tiny quarter burr. That way you don't get a lot of suction. And if you do hit it, the bleeding is not nearly as severe, but it's usually going to be the mandibular artery. But I get more calls about the infraorbital, actually.
And then when I'm on the phone saying, what do I do? What do I do?
What I do, I'll tell you what I do. I say, first thing, take a breath, calm down, pack off the area. Usually I'll use a gauze and just pack it into the wound. You can use bone wax or some other product as well. And just step back, go somewhere else in the mouth, work on another spot. Let that sit for a while. Let your blood pressure calm down a little bit as well. Work on another tooth, do something else. Come back in 10 minutes or 15 minutes. Gently remove the packing that you put in there, and recognize that you have a vessel there that you're going to protect, and be very, very, very careful with how you continue with the procedure. Some folks will just stop the procedure at that point and say, okay, we're going to do everything else, but we're going to leave this in place and we'll come back and deal with this later. And that's perfectly fine, but recognize you still have to come back and deal with whatever you left in place there once everything heals. But more times than not, I just pack it off, go somewhere else, come back, and recognize I need to be very careful when I come back.
And about 10 or 15 minutes before you touch it. So
yeah, no magic there. Just I do
set
something
a timer, do something else.
Yeah,
that's always my problem, is like I want to go look at it too early.
Right. As soon as you pull it off and it starts bleeding again, put it back, go do something else again. All bleeding stops eventually, right?
Yes. Although I've heard of things like having to tie off, the jugular in order to stop it from bleeding or something. And so those are the ones that give me nightmares.
Yeah, unfortunately, I've never had that occur where I've gotten to
Good.
that point. I've had some pretty significant bleeding in some of our tumor surgeries and working inside the nose, but still never got quite to the point where I need to start tying off the jugular
So
or the
this is,
carotid.
or the
Yeah.
carotid, yes, the
Yeah.
carotid. Okay, good. So that's not something that really needs to be keeping me up at night.
No, you don't have to. Just be careful when we do our surgery, and if it bleeds, just back off and try again in a minute or two.
Are there any specific perioperative testing or medications that you use in some of these breeds that we know are prone to bleeding, like Dobermans or Sighthounds?
Yeah, you know, honestly, I may be in a slightly different position than most because my patients come to me from other practices, and so they usually come to me with a diagnosis of a problem like that, and we're already on top of it. It's pretty rare that I see that. Honestly, I don't even hardly see Dobermans anymore. They don't seem very common, like they used to be super common back in the 90s when I first graduated. But usually they come to us with a diagnosis that this is a von Willebrand's case, or this greyhound's been bleeding before. So I don't typically do any preoperative testing on these guys that are specific. Bleeding time tests are valuable, particularly for your both of those really, whether it's just what do you call them? Doberman, sorry. The Doberman doing a buccal bleeding time test is valuable for them if you don't know about von Willebrand's. Good surgical technique. I just don't get a lot of bleeding anyway. I have had a few greyhounds bleed post-operative, and so I'm maybe a little more sensitive to that now than I was, and starting them on some meds after surgery might be wise if I have no history that they've had any surgery in the past. But if they've had surgery previously, I don't think it's a major issue if they didn't bleed on their
Mhm.
spay or neuter or whatever other surgeries they've had.
Okay. So finally, I was really hoping that you could share with our audience, how do you approach talking to clients about the potential for these complications, or, if and when they do occur, the follow-up care that is required, the cost that goes with that, possibly referral? Like, how much is too much information for these people to not scare them, but also to make sure that they have informed consent?
Yeah, that's tough because every client's different, and so I walk a tightrope with clients that come. And again, I'm a referral practice, so I tend to get some of the higher maintenance clients, and so I really sort of feel them out through the exam process to decide how much information I really should give them. Sometimes the clients stop me and tell me I'm giving them too much information, but I try to be open, and I'm a good communicator with the clients. I don't see a lot of really horrible complications in my hands. I do mention the potential for fractures. Now, if I know we're getting it's a pound and a half Yorkie, and their teeth are all rotten out of their head, and there's a pretty good chance that we're going to have very little bone there. So I do warn them that can happen, but I also let them know that if it does happen, we'll deal with it. You're in the right place for that as well, and so we can take care of the fractures if they occur. Post-op bleeding, that's a discussion I typically do have with greyhound patients and for clients, so that they know to keep an eye out for that. But again, I don't get into the minutia too much because I think it tends to scare people a little bit. But I definitely tell them about what I think is most likely to be a problem, and that's
So
case by case.
picking those conversations, especially, if we have a breed, like you said, or those dachshunds, that we think, we have a higher propensity to see some of these issues with.
Yeah,
So,
yeah. Every dachshund gets that discussion just about before we put them under that we may have an oronasal fistula present, and
mhm.
might have to do surgery to fix that.
Okay. Well, that was all of my questions about complications from dental procedures. It was wonderful. I actually learned quite a bit, and it's going to be a little bit more comfortable. Maybe I'll be a little bit more adventurous, but I still probably refer a lot of those.
Oh, you can do it. I know you can.
So we like to end our podcast episodes with a little fun game. Okay, so some more questions for you, but these ones are just for fun. There's no right or wrong answer. Would you like to play our rapid fire game?
Oh, I'll give it a shot.
Okay. All right, so
Go-
first
go-
question. Would you rather redo your residency or go back and redo high school?
Oh, goodness gracious. I would rather redo high school.
You would rather redo high school.
High
Excellent.
school,
High school was fun.
it was kind of a party time for me, so it was a lot more fun than the residency was.
Are you the kind of person that would rather learn a new skill every year or hone one skill and be the best in the whole world at that one thing?
Wow, I would say both, but if I had to choose, I'm a perfectionist, so I guess I would go with honing one skill really, really well. But I love to learn new stuff. My email says it right at the bottom. It says learn something new every day.
Well,
And so
yeah, absolutely. You went back after 24 years to do a residency. So. Okay. Oh, this is for you because you're in Maryland. Would you rather pick your own steamed crab, like on the table with the brown paper, or have somebody else do all that work and have a nice big lump crab cake?
Well, I moved from Maryland to Virginia. I'll say that first. But the answer to the question is easy because I do not do anything with food. Somebody's going to have to pick that crab clean for me, or I'm not going to even order it.
That picking that crab takes forever. By the time I'm done, I'm like, this is all I get to eat? It's not my cup of tea either.
The shrimp come peeled and the oysters come already open.
All right. Would you rather practice without local anesthetics or without digital dental radiography?
Hard. I can't practice without digital radiography, so I would say we can manage with system or with general anesthesia better than I can manage without radiographs because I can do anything without a radiograph. It's impossible.
Well, I was thinking that you have like CTs and all sorts of fun other things that you might be able to do, or you could just like hand dip them. Before we had we hand dipped them before we had digital.
Sure, I did too. If you include all that, then maybe I would change my mind.
Then maybe change. Okay.
I meant radiography in general, but CT is incredible. I can virtually only use CT if I had to. It's great.
Yeah. Okay. Last question. This one is the most important. If they were still both alive, would you rather extract the maxillary canine on a saber-toothed tiger, or would you perform a root canal on a woolly mammoth?
Wow, the extracting the tooth from the tiger would probably be easier, so I would go with that one. The root canal on a woolly mammoth would be really, really hard. I saw somebody wrote an article about a root canal on an elephant, and it was quite the process. And so I'm not going to do that. I'll take the tooth out.
We'll take the giant canine tooth out. Awesome.
I'm all about that.
All right, that was it. See, it wasn't so bad, right?
I passed.
You passed. It was great. I want to just say thank you again for just taking the time to sit down with us and share with our audience all of these wonderful pearls and insights. And I appreciate your time and your commitment to the field.
Oh, well, thank you for having me. This is great.
Thank you all for listening to today's episode of Clinicians Brief, the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version that we have on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts. Or, if you'd like, drop us a line at podcasts@vetmedics.com. Clinicians Brief the Podcast is a VetMedics production, produced by Alexis Ussery and hosted by me, Dr. Alyssa Watson.